In gastric cancer, I do not think the concept of maintenance therapy has been accepted yet, unlike colon and lung cancer. However, due to the toxicity of platinum agents, cisplatin and oxaliplatin, it cannot be used for a long period of time. So, fluoropyrimidine monotherapy is often used as a single agent during first-line treatment. This would result in performing maintenance therapy. I think this is continuation maintenance, so to speak. In terms of switch maintenance therapy, there have been trials with IOs and both ipilimumab as a CTLA4 antibody and avelumab also a CT-PD-L1 antibody, it is Javelin Gastric 100, have had negative results in overall survival. So maintenance strategy for advanced gastric cancer has not been established at this moment. However, theoretically, and considering the mode of action of IO, maintenance strategy in IO treatment is, I think, it is not long direction to go.
Maintenance therapy in gastric cancer is not a standard of care yet. So despite this, many experts and oncologists use a type of maintenance therapy. So the decision to go for a maintenance therapy is based on individual characteristics of the patient, like patient's perspectives and response, etc. So I think that many oncologists, for example, they do de-escalate the chemotherapy regimen from a triplet to a doublet, or from a doublet to a monotherapy after 4, 6, or 8 cycles of treatment to reduce toxicity. However, there is no studies to show that maintenance therapy is more active than no maintenance therapy. I personally like in patients who are HER2 positive to eliminate the platinum and continue the treatment with the HER2 antibody plus the fluoropyrimidine after approximately 8 cycles of treatment. But there's no clear standard of care in terms of the maintenance treatment.
With respect to the issue of maintenance therapy for gastroesophageal cancer, we don't have a lot of evidence to support this. That said, we do extrapolate from other tumor types, like, for example, colorectal cancer, where we have the Optimox studies, Optimox 1, which was dropping the oxaliplatin and continuing with the fluoropyrimidine and intermittently adding the oxaliplatin back in, and Optimox 2 study, which was going on a complete chemotherapy holiday and then intermittently adding the chemotherapy back on. So we have data to show, especially in Optimox 1, that by dropping off the oxaliplatin, we can limit the buildup of cumulative neurotoxicity, which is one of the main issues, and also therefore increase the longevity of using oxaliplatin over time by intermittently adding it back in. In those studies, it was added sort of routinely in a regimented manner, 2 months on, 2 months off. In our practice, both in colorectal cancer and in gastroesophageal cancer, I stop the oxaliplatin after 4 months, which is usually that time at which neuropathy is really starting to creep in, and then go on monotherapy fluoropyrimidine, whether it's IV or oral, and then I reserve the reintroduction of oxaliplatin for if and when there is actual resist progression or tumor markers starting to increase, or increasing of symptoms, or a combination thereof. And so that can really be, I tell my patients, years before we have to introduce that. And on the other hand, it could be after even just 2 months of being off the oxaliplatin that then you're starting to see signs that you need to start thinking about reintroducing it. So The only other thing to say is in the HER2 positive tumor type, which of course is about 15% of our gastroesophageal adenocarcinoma patients, we would include the trastuzumab therapy there, along with the fluoropyrimidine as a maintenance, and then again, intermittently adding the platinum agent back in. I will say that probably about 50% of the patients are still not able to reintroduce the platinum agent later on in my practice, and that's because they still have residual neuropathy that we don't want to push. And so then at that time point, we would switch to second-line therapy. But there are a number of patients that you can reintroduce oxaliplatin and then regain control for a period of time and not use up later lines of therapy.